features that will identify both clinically and by laboratory the ability to differentiate causes of optic neuritis and to look at those causes of optic neuropathy and optic neuritis that are at high risk for poor visual recovery or recurrence. And then to look a little bit at current treatments for optic neuritis. And we'll do all of this in a case-by-case approach. So let's get started. I want to talk about first a 45-year-old woman with vision loss in the right eye. She had vision loss for approximately 3 days. Vision was maximally cloudy in about 2 days, and she had poor color vision. There was pain in the affected eye that worsened with eye movement, and she had no additional neurologic or ophthalmologic complaints. Vision in the right eye was 6/18, normal in the left eye with color saturation and a right afferent pupillary defect. All other examination findings were normal. And that was a typical case of optic neuritis. What makes it typical? By virtue of the 150 patients enrolled in the optic neuritis treatment trial in 1993, we know that eye pain, 90% of patients, and peak deterioration in 2 weeks are the seminal clinical hallmarks of optic neuritis, painful acute vision loss. Visual acuity is often worse than 2100 in 80% of individuals, or better than 2100, and color vision loss and an afferent pupillary defect are the key other additional clinical signs. Visual field loss can be diffuse or central. In 65% of patients, the optic nerve looks normal. However, in about 30% of patients, there can be some minimal optic nerve swelling, some difficulty clearly following the vessels over the disc surface. But rarely do you see severe disc swelling and hemorrhages, as can be shown here with some hemorrhages in both optic nerves. When we want to test for our presence of optic neuritis, the most sensitive test is an orbital MRI, where about 95% of patients will show acute T2 or T1 GAD enhancing lesion, as can be seen here in that right eye. But a brain MRI scan, important for looking at future risk of multiple sclerosis, will only detect the optic nerve lesion in about 30% of cases due to differential sectioning and the lack of fat suppression. But visual evoked potentials and optical coherence tomography are nonspecific and non-sensitive. They can indicate the presence of optic neuropathy and optic disc atrophy, but they're not specific for optic neuritis. And why is that the case? That's because what we're measuring for retinal nerve fiber layer thickness by optical coherence tomography in the peripapillary retinal nerve fiber layer is something of an event that's happening at the retrobulbar optic nerve. And so degeneration has to proceed from the retrobulbar optic nerve to the front of the eye for us to measure it. And as can be shown on the right, only about 50% of patients will have significant retinal nerve fiber layer thinning by 3 months after their optic neuritis, and it usually takes about 6 months to see the full extent of optic nerve atrophy. Within the retina itself, we can measure the ganglion cell layer as shown below between the black bars, and in this ganglion cell layer in which the cells represent about 70% of the cells projecting axons through the optic nerve, because of a lower coefficient of variance, we can see that atrophy a little bit sooner, but perhaps not soon enough, as indicated in this chart, where we look at the months following the optic neuritis on the left and the area being measured on the right, and you can see that about 3 months after optic neuritis, the mean retinal nerve fiber layer thickness and the temporal retinal nerve fiber layer thickness begin to show atrophy. However, for the ganglion cell layer, we can see such changes at 1 month, but that's still not when the patient is presenting to you with original symptoms. And finally, we know from this optic neuritis treatment trial that there's no difference in visual acuity and outcome at 6 months between those patients receiving intravenous methylprednisolone at high dosages, 1 gram per day, and those who did not. However, the time and the rate of normalization of the visual fields, contrast sensitivity, and visual acuity do happen faster. So you don't get to a different outcome, but you get there faster. What's the problem with all of this? This was done pretty much in the United States. It had a limited ethnic diversity. There was a high proportion of patients with idiopathic optic neuritis, and there was no patients with neuromyelitis optica optic neuritis, and only 1.7% of the participants had the newly discovered 𝐬𝐒 𝐒𝐲-associated optic neuritis. So let's go to the next case. This is another patient with painful central vision loss that was maximum 3 days. However, this time both eyes are affected. Because both eyes are affected, there's no afferent pupillary defect and the normal neurologic and eye exam otherwise. Here's this patient's MRI, and if you look here with the prominent optic chiasm involvement, as well as this fluffy hypothalamic enhancement here, one might guess that this is a case of a patient who tested positive for aquaporin 4 IgG. So this is a case of neuromyelitis optica optic neuritis. And what is neuromyelitis optica? It is a recurrent inflammatory disease of the nervous system that often presents with optic neuritis and transverse myelitis. About 45% of patients will present with optic neuritis at onset. Ariopostrema, brainstem disorders, diencephalic syndromes, and cerebral symptoms can also happen. About 90% of patients with neuromyelitis optica spectrum disease under the new criteria are positive for aquaporin 4 antibody. And what clinical clues you can use for differentiating this form of optic neuritis might be a prior history of intractable hiccups or nausea, vomiting, and perhaps a prior history of encephalopathy. In neuromyelitis optica optic neuritis, vision loss is severe. And why do we treat? Because 70% of patients will have permanent vision loss in one eye by 8 years untreated. And compare that to the natural history of MS, where only about 8% will ever have significant uncorrectable vision loss. The mean nadir of visual acuity loss in this disease is severe, 6/120 or less in about 90% of patients, where only about 20% with MS-related optic neuritis will have that severe a vision loss at nadir. Bilateral optic neuritis is more common at 20%, and mean visual recovery is poorer. It is 6/6 in optic neuritis from MS, 6/15 roughly in NMOSD. This is meant to point out that with corticosteroid treatment for NMO optic neuritis, as can be seen in the left-sided graphs, the amount of patients with complete recovery is very minimal. It's about 12% of patients. And this is out of 800 acute episodes collected in the NEMOS cohort in Europe. And repeated attempts to make it better with corticosteroids doesn't provide much improvement. You only get a small fraction of patients who go from no recovery to only partial recovery. However, shown on the right, you can see that there is greater improvement with the use of immunoabsorption or plasma exchange. And this is particularly notable for patients with myelitis, but I'll point out in this next slide that with optic neuritis, plasma exchange or immunoabsorption improves visual acuity outcome, visual field outcomes, and residual retinal nerve fiber layer thickness as measured by OCT. What's important to note about all this is that plasma exchange has to be done early. There's a tipping point roughly at about 5 days after onset of vision loss where the efficacy of plasma exchange is lost compared to when it's given initially. So when you have to recognize neuromyelitis optica early, because early initiation of immunoabsorption or plasma exchange can lead to better recovery. Here's an 18-year-old man who 6 months prior to this episode had optic neuritis that was treated with intramethylprednisolone and had excellent recovery. Now on rituximab for presumed multiple sclerosis, he has bilateral optic neuritis. That is 6/12, 6/9 in both eyes with bilateral disc pallor on exam because of his prior optic neuritis history. And he has a negative serologic workup. You can see he has bilateral enhancement of the optic nerves on MRI and these longitudinally extensive intraorbital lesions on axial imaging. As you might expect, this patient has 𝐬𝐒 optic neuritis. We know that optic neuritis, as shown in the orange graph on the left, is a prominent cause both in pediatric and adult 𝐬𝐒-associated disease and in pediatric combinations with recurrent optic neuritis and optic neuritis and transverse myelitis presenting like NMO disease. You can see a majority of pediatric patients present with optic neuritis as well. Clinical clues for MOGAD optic neuritis include bilateral onset and a high recurrence rate, anywhere from 35 to upwards of 50% in some studies over 3 years. Vision loss is severe, like with NMOSD optic neuritis, and pain is often prominent, with a high tip-off on fundoscopic examination being optic disc edema, which happens almost in 85% of patients, and compare that to 30% with MS optic neuritis. Visual recovery is good, as shown in the white portions of the graph here for bilateral and unilateral optic neuritis, as well across the age groups. So here we have a prominent vision loss with good response to corticosteroids, with average final visual acuity in 615 range, and rarely do you have vision loss worse than 660 with this disease. Here's a 37-year-old man with meningoencephalitis and transient visual obscurations, normal visual acuity, no afferent pupillary defect, and superior arcuate field loss in both eyes on visual field testing. You can see the prominent disc edema in both eyes. This is a case of GFAP, gliofibrillary associated protein optic neuritis, which is a monophasic course in many patients, but can have a relapsing or progressive phenotype in others. The periradial MRI enhancement is a tip-off for this diagnosis, but you will not see MRI inflammation of the optic nerves. This is optic disc edema coming from a papillitis, and intracranial pressure will be normal. Most patients are responsive to steroids, but there's a high risk of recurrence on steroid withdrawal. Other forms of inflammatory optic neuritis include collapse-mediated protein 5, CRIMP5 optic neuritis, which is a tip-off for bilateral disc edema and vitritis, and a picture of this CRIMP5 optic neuropathy is shown on the right. Optic nerve autoimmunity with recurrent immune-mediated optic neuritis or chronic relapsing inflammatory optic neuritis being idiopathic causes, as well as sarcoidosis, where optic nerve involvement and ocular involvement are prominent in about 50% of cases, and your tip-off can be inflammation, infiltration, and compressive findings, both by seeing panuveitis, retinal periphlebitis, and neovascularization with these cases. And here's a case of a longitudinally enhancing optic nerve lesion with sarcoid optic neuropathy with the typical histopathology showing non-necrosing sarcoid granuloma. A 42-year-old man with a splotch of visual change in the right eye, even though he has normal visual acuity, he still has an afferent pupillary defect pointing to the optic nerve being involved. And he had 5 weeks prior a fever and a rash with some increased tone and hyperreflexia on examination. Serologic fundoscopic exam, first shows swelling with hemorrhages in this right optic nerve, and serologic presentation was positive for an FTA-ABS for neurosyphilis. So this is an example of syphilitic optic neuropathy, and I just want to point out that infectious causes of optic neuropathy are prominent and need to be treated for the causative organism. But typically, with infectious optic neuropathies, you'll see prominent inflammation in the retina, and with Bartonella-Henselae or cat scratch disease, neuroretinitis can often typically form a macular star. What are the principles for managing optic neuritis? I want to point out that because of the spectrum of causes of optic neuritis, the prognosis is not uniformly good, and you need to initiate therapy appropriate for that diagnosis in order to maximize visual recovery. And there are important imaging, CSF, and serology data that can have you an immediate clue to what to do for these patients. When it comes to imaging, please note that the optic nerve signal change is not going to be that helpful. All of these conditions cause T2 signal change, gadolinium enhancement. But for MS, focal lesions are key. And as can be shown on the right, a focal intraorbital lesion with MS-related optic neuritis. And you can see those that are prominently in the canal or in the orbital space. Posterior, as shown in unusual case here on the right, in the intracranial section, is unusual for multiple sclerosis, about 10% of the time. But it is more typical for neuromyelitis optica, where posterior intracranial lesions or involvement of the optic chiasm, as shown here, can be a prominent clue. It's not an absolute clue, however, because optic chiasm can be involved with MOGAD disease. And in MOGAD disease, your tip-off is going to be that the longitudinally extensive optic nerve lesion reaches back to the chiasm when the chiasm is involved in MOGAD. When it's involved in NMO, it's often in isolation. And for MOGAD, you can have prominent perineuritic enhancement with extension of inflammation into the orbital fat, which is very atypical for NMO and MS-related optic neuritis. Laboratory clues. While we can get multiple serologies that complicate cases, they're typically more prominent for GFAP IgG disease and occasionally anti-GAD antibodies and thyroid and myasthenia antibodies in concurrent neuromyelitis optica. So checking for other serology can sometimes be a helpful clue if you don't have access to other means of testing. In the CSF, pleocytosis is generally higher for MOGAD than in other conditions, and eosinophils in the CSF can be a prominent sign of NMOSD. Oligoclonal bands, while high in MS and in GFAP, are low in MOG and in NMOSD-related optic neuritis. So the CSF can be helpful indirectly as well. It is not worth testing for CSF antibodies in NMOSD. However, in MOGAD, as I'll talk about later today, it is part of the new diagnostic criteria and may be helpful if clinical suspicion is high. What's going to be poor prognostic signs of optic neuritis visual recovery? It's going to be worse than 6/15 vision at 4 weeks, a diagnosis of NMOSD, or the features of recurrent optic neuritis, because once the optic nerve is damaged, a repeat episode of optic neuritis is not going to have the same positive aspects for potential visual recovery. You can use the OCT machine, if available, in MS-related optic neuritis to prognosticate based on ganglion cell interplexiform layer thinning. While I noted to you that it is the earliest sign of optic nerve injury, roughly 1 month after optic neuritis, GCIPL thinning that is significant and greater than 7 microns is a sign of poor visual recovery in MS-related optic neuritis. And coming up in the future, OCT angiography, just a different way of using a swept source OCT machine to look at vessel flow within the retina, can show differences between NMOSD and MS-related optic neuritis and may be able to help us differentiate at the acute setting. So what are future neurotherapeutic avenues for optic neuritis? There was an old phenytoin trial that was performed in the UK in a phase 2 looking at neuroprotection in optic neuritis, and there was successful evidence of reduced retinal nerve fiber layer loss in acute patients with optic neuritis based on sodium channel blockade. This may be an important avenue to explore in future acute treatments. We now have early trials at remyelinating agents that have been shown by looking at VEP latency recovery to show some improvement in cases of optic neuritis. And we have more pertinent anti-complement and IVIG therapies that could offer avenues for acute treatment of specific forms of optic neuritis, namely NMOSD. So, to summarize, it's important when we're thinking about optic neuritis as a prominent cause of recurrent inflammatory disease of the nervous system to identify the cause. If it is infectious, you're going to look for other inflammatory clues in the eye, and when it's infectious, you need to treat the underlying organism. You can use other clinical imaging and laboratory clues that I gave you to try to differentiate amongst causes of optic neuritis. While the prognosis is usually good, recurrent optic neuritis and NMOSD are the most prominent exceptions to that rule. And while intravenous methylprednisolone is the mainstay for improving the rate of visual recovery, early plasma exchange for NMOSD and recurrent optic neuritis, if available, need to be entertained and done soon. Future objectives are going to be more at directed therapies and prognostic biomarkers and learning how we can potentially repair the optic nerve at the myelin level, that is remyelination, to get us to a better outcome. And I thank you all for your attention and again for the kind invitation.
Thank you, Professor Bennett, for the great lecture. I think there is no time for discussion, and we end our session today. You have a question, Professor? Professor Bennett, one question for you, please.
Sure.
Can we use phenytoin with fingolimod to prevent the retinal fiber affection?
Well, there's no evidence for fingolimod, but phenytoin in an acute setting has shown protection for retinal nerve fiber layer loss and acute optic neuritis at standard 300 3 times a day dosing. So it is potential. The one thing I will point out is while the retinal nerve fiber layer loss was protective, the outcomes didn't change. So VEP was not changed, visual acuity was not changed, both high contrast and low contrast, as well as visual fields. So functionally the outcome wasn't different, but the retinal nerve fiber layer thickness was preserved by a significant difference.
Thank you, Professor Bennett. I think that's all. We don't have any time for any questions. So, Professor Naveen, okay. Very small question.
Thank you for the extreme.
I'll give you a very small answer too.
Updated brainstorming lecture. The IVIG role in optic neuritis along the spectrum of optic neuritis. It was not mentioned. So, are they not effective, and why?
So IVIG, is that what the question was? Yes. So there is one study from China that I gave credit to here, and they found a significant difference in treating NMOSD patients with optic neuritis with IVIG and finding a successful result when compared to methylprednisolone. However, that study did not evaluate side-by-side plasma exchange. However, every other study in IVIG and MS-related optic neuritis and idiopathic optic neuritis has not shown a significant difference versus methylprednisolone. So in my practice, I don't use IVIG. If I'm worried about a patient, I use plasma exchange. But if IVIG was the only thing available instead of plasma exchange for, let's say, a case of NMOSD, I would use that aggressively.
Last question, please, Professor Bennett. Ask you,
Yeah.
If a patient presents to us by bilateral optic neuritis severe, can you prefer to use plasmapheresis as a first line of management? You are expecting that the use of pulse steroids may not be the option which will give us a good outcome?
Yeah, if someone has bilateral optic neuritis that's severe, those two entities that I pointed out, NMOSD-related optic neuritis and MOGAD, are high on the list. If I have high suspicion for MOGAD, that is based on the appearance of a longitudinally extensive optic nerve, particularly perineuritis, then I'll go to steroids first, because often the steroid response is very quick and is very good. However, if I'm suspicious about NMOSD, then I would go directly to plasma exchange, particularly because of the need for plasma exchange in this condition. I will add one thing, and that is, you're okay in my book to be wrong and to have overtreated with plasma exchange when you find out after the fact that it was something else, just because the threat and the lack of information coming in quickly enough may be important, because you have about 5 days to really get the maximum effect from plasma exchange.
Thank you, Professor Bennett, for the great lecture and the great discussion. And now we are ending our session, and then we are going for the break for prayer, and we will be back by 1:30 p.m. Thank you very much.